having me here. We have had lots of how to do things since yesterday. My talk will primarily be focused on when and why should we choose the right approach for angiofibroma tumors. As we were discussing in one of the previous sessions, this is one of the Indians' favorite. Unfortunately, we are the angiofibroma predominant country in the world. And there are reasons, and possibly one reason is that we have large number of this population. I sincerely acknowledge, because my institution has taken a lot of lead in contributing to world literature on this, and I acknowledge my colleagues, Dr. Alok Thakkar, Dr. Hitesh, and my resident Stavan for helping me put these slides together. That's a typical slide from our postgraduate seminar series where we put it as a typical case of advanced angiofibroma. You will be looking at an adolescent male. It's exclusively a disease of males. And predominantly, 90% of these cases, they were present with nasal mass, nasal obstruction, and epistaxis. The surface appearance may slightly differ. I have put in 3 different angiofibromas. You can see they may appear very red with lots and lots of congested vessels on the surface. They may appear pinkish, and they may appear slightly whitish because of some slough, some superficial infection, and some degree of necrosis. We were discussing about stagings. If we look a couple of decades back, the extreme right 2 or 3 staging systems were used. We have all used Chandler's, we have all used session staging system, but they have more or less been extrapolation of staging of nasopharynx cancer, which this tumor is not. What we employ at our institution currently is the Redkowski staging system, and there are good reasons why this is a very valid staging system for choosing the right and appropriate approach for excision. And this is predominantly the reason that we like. If you look at Redkowski 2C, it has started looking at tumors that are extending posterior to pterygoid plates, and it's a very, very important factor in decision making, in choosing the right approach in approaching this type of tumors. It's a very peculiar tumor. Few factors I have put. Exclusively a disease of adolescents, exclusively a disease of males, but it has got very consistent characteristics. I had heard one of ENT surgeons in a reputed ENT conference saying that there are babies waiting to be delivered, which is not exactly the case always, but it is one of the most predictable tumors in head and neck armamentarium. There are few reasons for this. It always arises from pterygopalatine fossa. That's a publication from my institution only. My colleague, Dr. Arvind, has refuted and possibly stated the origin to be from the palatovaginal canal, but they are all adjoining areas. This will always originating from this 1 centimeter or so epicenter of origin. This has got predictable patterns of spread, and we have all read in our ENT textbooks on how this tumor spreads laterally, anteriorly, and also intracranially, and it will almost always follow this pattern with some exceptions. It's always attached to the area from which it originates, and primary tumor, except if it's not a recurrent tumor, will always have consistent attachments in those areas. It will not unduly attach to areas of mucosa, in septum, intracranial dura, and so on. Vascular supply, my previous speaker was alluding to, is always predictable. It takes its blood supply from maxillary artery. Sometimes it takes the supply from IC also, and it's predominantly the median artery. It's bound by dural folds. Even with large intracranial extensions, the primary tumors will not adhere to dura. They will not attach to dura. It will not be very difficult to separate it from dura. Even this is a recurrent tumor. You can see it filling the orbit, but it will always lie pushing the dura, not attaching it, unless that area has been previously violated. Treatment of choice is definitely surgery. For now, we might have some future medical treatments as we were discussing, but there is some role for watchful expectancy, especially in residual tumors, and we have had reports of very large tumors disappearing with radiation therapy also. But till date, if you ask one treatment, it's definitely the complete surgical removal. Intent of treatment, I have listed here. You should have a good access to routes of extension wherever the tumor has reached, good access to vascular supply to attain the vascular control, minimize blood loss, as much less blood loss as possible, minimize cranial nerve injury, Do not disrupt the growth centers, because this is a disease of growing males. Do not disrupt growth centers. Also take into consideration cosmesis, minimal brain manipulation as far as possible, and you should also have consideration to soft tissue injury, pain, scar, and if possible, you should avoid external radiation as well as gamma knife treatments. If I make this statement in this forum, probably many of you will be supporting me that all angiofibromas can be operated endoscopically. Maybe right, if you have good experience, if you have good infrastructure, if you have good equipments available, but we should have an open mind for open approaches also. And predominantly at my center, I'll be talking about the last three: the maxillary swing, midfacial degloving, and the preauricular subtemporal approach. When the patient comes to us for angiofibroma treatment, these are the factors that we take into consideration. Sir had very rightly mentioned about the factor. It's not about age entirely, but it's about the body weight. A 15-20 kg boy is going to be different than a 40-45 kg boy, because you have got less leeway for a blood loss. Disease extent. What is the stage of disease? Very important factor for consideration in our series. What's the vascularity pattern like? What is effectiveness of embolization? We were talking about the Pittsburgh staging. What is our experience or the experience of surgeon who is operating? And do you have all available technologies? And we don't talk about much is whether the patient has a revision surgery and he has a pre-existing facial scar. A person who already has a scar on the face, I will probably not be too much bothering to avoid that facial scar again. We have published the anesthesia aspects of this, and it's very prudent to mention on this forum the importance of hypotensive, good anesthesia, equipment like cell savers, and preoperative embolization. One thing that has changed over few years is that the tumor originates from the Vidian canal, and you should expose that area, drill the Vidian canal well, and we can avoid the recurrence rates substantially that ways. As I said in our previous discussion, we also follow a preoperative volume reduction, and routinely, especially large tumors, receive flutamide therapy for 6 weeks if they are stable enough. And we have achieved this reduction as much as 40% with this medical treatment, but it's only for post-pubertal males, not for pre-pubertal males. For endoscopic approaches, you need to have some set of equipments, a good endoscopic suite, cameras, all degrees of endoscopes, good skull base set with the drillings, equipments, burrs, and if possible, endoscopic navigation system. What has not been discussed widely is use of coblation. I feel it's excellent tool for vascular tumors. It provides you suction, ablation, irrigation in one go, and it's a routine for use in our series in angiofibroma cases. It's an honor to be in front of Dr. Nikolai. Few of the proponents, they were one of the earliest to describe how the endoscopic excisions are performed. There are very few head-to-head comparisons if we look at literature in endoscopic versus open approaches, very few, and all studies are biased. Small tumors, endoscopic, big tumors, open approaches, but that's what one of the largest analysis says. It's more than 1,000 cases. There is no difference in outcomes if you talk about recurrences or residual tumors, but blood loss is less with endoscopy. That's what this largest literature has taught us. I'm not talking about video because we have already discussed a lot about how we are doing this. Open approaches have their value in too much of anterior extent in the nose. If the tumor is filling the anterior nasal fossa, they are difficult to access purely endoscopy, and that's where the modified Denker's approach come in. You can do it purely endoscopically, but what we use at our center is a modification where we employ, and sir had shown it in his video, a sublabial incision with exposure of anterior, a wide anterior enterostomy, and complete exposure of tumor by removal of part or full medial maxillary wall. If the tumor looks like this, that is, it has bilateral extension into the nasopharynx, but it's not going too much up into intracranial or too much of sphenoidal extension. What we have used for the years is a midfacial degloving approach. This approach is bilateral sublabial approach with septal elevation, which exposes your complete mid face. Very good approach for 2B, 2C Redkowski angiofibromas. For large lateral extensions and intracranial extensions, what we like to use is the mid-facial degloving, is the maxillary swing approach, where we make the Weber-Ferguson incision as we do in maxillectomy, and we pre-plate all the maxillectomy cuts. Make sure that your skin is not elevated off the maxilla, and after making the cuts as in maxillectomy, we swing whole of this skin with the overlying maxilla and expose the tumor. A very useful approach for large lateral extensions like this if you are not contemplating an endoscopic excision. We have also modified this maxillary swing to incorporate the opposite side nasal bone and some part of medial wall, and it's a modification what we call as facial translocation approach. Again, an excellent approach for ipsilateral large lateral extensions. The advantage of these open approaches is that you can use both the hands and dexterity improves, and you can also employ the historical finger dissection for excision of tumors. These approaches are not only good for far lateral extensions, but provide excellent exposure of central skull base, sphenoid sinus, plenum, as well as clivus. Vidian drilling can be bimanual, bidextrous, and must be done to avoid recurrence of tumors. Intracranial extension is a very, very tricky topic. And at our institution, we have described 3 types of intracranial extension. If you look at the first type, it's more a midline tumor, directly invading or going through the fovea ethmoidalis, plenum sphenoidale, and some bit of extension through the lateral wall of sphenoid can be approached by your swing approach. Second one is the more typical extension by expansion of superior orbital fissure. Third, Sir was alluding to, very, very tricky. It's directly eroding the greater wing of sphenoid, widening the foramen ovale, and possibly too much of marrow invasion in that area. And this is the trickiest part, for which we employ the preauricular subtemporal approach. This approach we do with neurosurgeons, of course, where they do a trional craniotomy for us. We elevate the temporalis muscle down completely, expose the zygoma, make the pre-medicated zygoma cuts after pre-plating it, remove the zygoma, and accordingly, we remove the coronoid and, if required, condyle of mandible to expose completely the infratemporal fossa. Exposure of temporal lobe, frontal lobe dura, tumor, as well as orbit is excellent. And good thing is that you can attack the tumor laterally by ligating the internal maxillary artery in this region. And you can also extend the incision down if you have to take control of external and internal carotid artery down in the neck. That's the complete ITF after tumor excision. So, summarizing the intracranial extensions, type 1, you can access with maxillary swing or midfacial degloving. If it's expansion of superior orbital fissure, you can employ the lateral preauricular or maxillary swing. And this type of extensions, what we have shown, if they are too lateral, it's better in our experience to use preauricular subtemporal approach. So that's the summary of my talk. I have listed endoscopic in all the stages because it depends on the experience, equipment, and expertise that you have. Stage 2C, maybe sublabial or swing. If you are not too much into endoscopic, lateral extensions, swing, and endoscopic. Intracranial, if it's small, medial intracranial extension, you can use maxillary swing, and too much of lateral intracranial extension, employ the lateral subtemporal. I reviewed the data a few years back on our angiofibroma experience, and I found that blood loss with pure endoscopic, it might be a biased statement to make, is much more if you are dealing with recurrences and revisions. So for recurrences and revisions, unless they are very small, our choice of approach is more open rather than pure endoscopic. Thank you very much for your patient listening, and I invite everyone to Indian Society of Thyroid Surgeons meeting, which is happening in New Delhi on these dates. I request all youngsters and experienced to register for this. Thank you.